Have you ever done an axial bifemoral bypass?
Yes, sir.
Do they still do those necessarily today, or is that I understand that there's something that they don't really do that much anymore.
No, it is still done. I would say the biggest setting in which it's done, and this is a fantastic question, by the way, in which we do an axilla, which means we go beneath your axilla, usually is on the right side, and we tunnel a bypass beneath close to your skin by the rib cage, and we go to each femoral artery. The number one setting in which we do this is when there is an infected aorta. So we can't suture where there's an infection because the bacteria they will eat our suture. So we have to go around it. Obviously, we could do nothing, but then you don't have circulation and you lose your legs. But by doing an axillobifem, that gives us time to give you the antibiotics to heal, treat that infection, and maintain circulation. That is, I would say, that one of the most common times in which currently we use an axillobifem bypass. That's a
I
very
have
good question.
one. I have one. It's totally blocked. Can't wear blue jeans. Can't ride a bike. Can't drive that long. Can't sit in the kayak because it pokes me. But it's. I understand it's totally occluded.
They do not have a long lifespan. They do not. The longer the bypass, the higher chance it's going to fail. The longer the bypass, higher chance it's going to fail. But even if you did fail that, there are always contingencies. You can do an aortal bifem, which means we go into your belly and we reroute it, or we try to open up your native arteries if that's not a possibility.
What we always tell people is, I mean, unless there is an infection, that the axillary bifemoral bypass it's rarely done these days, and it's a Hail Mary. It's more palliative care is the way I've heard it described, for the
A lot
most
of
part,
times, yes, yes.
because it is so temporary. We had a patient that actually ended up, she had a blocked aorta. It was known fresh clot because she forgot to take her meds for a few days, and they wanted to go straight to the axillary bifemoral bypass. I had talked them down from the ledge to do a thoracic, maybe because it could be more durable, but I said, why don't you go in? Why don't you do a TPA first? See if you could soften it up, at least go in. And it took us 4 days to convince the doctor. Well, he just left her sitting in the hospital bed, and I was calling the president of the HMO, and I was calling the vice president, and this one vascular surgeon who's the head of vascular surgery, um, wanting to kick the can down as far as he could. And I said, well, you're kicking the can down. Well, really not that far. No, they can last up to 7 years. I said, so what are you going to do with this 50-something-year-old lady after, in 7 years? You have no options for her. That clot's already dried up. You're not going to be able to go in the native vessels. What are you going to do with her? Well, it doesn't matter because that's the most durable thing that we can do right now. And I said, I think that we need to shift our way of thinking here on this one.
Oh, that's tricky. That's tricky.
It's
I
very,
think
so we,
we all have something to learn, and there's where sharing experience, sharing knowledge, with experts in different fields, no matter the specialty, is the only way in which we move forward.